My name is Jessica Lowe. I'm a research associate at CHeBA, the Center for Healthy Brain Aging at UNSW Sydney.
I'm Parminder Sachdev. I'm Professor of Neuropsychiatry at the University of New South Wales. I'm also the co-director of the Center for Healthy Brain Aging. I also work at the Prince of Wales Hospital as a neuropsychiatrist. Now, the Center for Healthy Brain Aging is a research center with the objective of actually improving aging research, especially in the brain, to see that people live long lives with a healthy, well-functioning brain. So we do a number of different things. Predominantly what we do is longitudinal studies of brain aging and dementia, which are population-based studies. But on the basis of these studies, we do various investigations looking at neuroimaging, genomics, proteomics, lipidomics, look at the mechanisms of brain aging, with the objective that finally we may be able to diagnose dementia early, maybe intervene so as to prevent dementia, and also improve healthy aging in the general population. Traditionally, the approach to stroke has been that people have focused on physical deficits after a stroke, say paralysis or weakness, and speech abnormality, for example, or say facial asymmetry. Those are the classical signs of a stroke. But people have not been focused very much on the cognitive outcomes of stroke as well, because the stroke affects the brain. And people who have multiple strokes, we know, often will come up with a presentation very much like dementia. And now increasingly, our studies show that when we actually see a patient after a stroke, we assess them, say, with 2 or 3 months after stroke, as many as 20% or so of these people would meet criteria for dementia. And in fact, about 1 in 2 will have significant cognitive deficits. And this is an area that has been neglected in the past. And I think increasingly over the last, say, decade or two, there is more focus on this. The main reason being that not only can we do something to mitigate the cognitive deficits at that time, but also to perhaps reduce the rate of progression of these deficits over a period of time. Now, there are different kinds of deficits that we see in these people. Commonly seen deficits are in, of course, what we call processing speed. So they're slower in processing information. That seems to impact a lot of their cognitive abilities. We also see deficits in memory, in language. Of course, stroke can happen anywhere in the body, anywhere in the brain, I should say. And therefore, deficits can be of various kinds, really. So in fact, every cognitive domain can be affected. And you also see global deficits. But we're seeing that increasingly in the early stages of these patients' abnormalities, the problems are in executive function and in processing speed, and certain kinds of memory deficits that are somewhat distinct from what we see in Alzheimer's disease.
COSMIC is an international consortium that was established by Professor Parminder Sachdev, who is the co-director of CHeBA. And COSMIC currently have 57 member studies from around the world that covers 39 countries across 6 continents. And these population-based studies, they are interested in cognitive aging in their populations, and they follow up their participants for a number of years. They've collected data on their cognition, on their health, lifestyle, as well as neuroimaging data and genetics data. And the aim of the consortium is to pull together the different member studies, and so we can have joint analysis and answer questions in relation to normal cognitive aging, mild cognitive impairment, and dementia. And so in our recent work, we included 14 of the 57 COSMIC studies, and that gave us over 20,000 participants, and that's a big number. And so with such a big sample size, that's one of the advantages of working with consortia data. It gives us really big sample size, and so that gives us great statistical power to answer questions that might be unresolved before.
Diabetes, hypertension, smoking, atrial fibrillation, obesity, for example, physical inactivity, others, other lifestyle factors like social isolation, they're also all considered risk factors for cognitive decline. We now recognize them as risk factors for dementia. And in fact, there was a Lancet Commission report first in 2020 and now in 2024. It has looked at 14 risk factors for dementia, which are potentially modifiable. And they may account for as much as 40% of the risk for dementia. So it is important to send that message out to the public that we can do something about it. And the important thing to recognize is that many of these risk factors occur early in life or start from an early age. For example, education is a protective factor. So poor education is a risk factor for that, and that comes very early in life. And then other factors like high blood pressure, diabetes, they act middle stages of life more so than later stages of life. So protecting your brain is a lifelong process. I think that is the message. And the way these risk factors act are through different mechanisms sometimes. But one of the things, of course, is that many of them are also risk factors for cerebrovascular disease. So it could be acting through cerebrovascular disease, either in the form of large vessel disease, which presents as stroke, or small vessel disease, which may not present as stroke, but as gradual increase in compromise of the cerebral vasculature. At the same time, some of these risk factors are also risk factors for Alzheimer's disease. We know that there is an interaction between vascular pathology in the brain and Alzheimer type pathology in the brain. So together, I think overall we see that we can actually, if we intervene on many of these risk factors, we may be able to slow the rate of decline and maybe prevent a significant amount of dementia in the population.
We found that stroke is associated with both short-term and long-term cognitive decline. And global cognition, which refers to the overall cognitive ability, as well as in different areas of brain functioning. And that includes processing speed, memory, language, and executive function. So processing speed refers to the time it takes someone to complete a task. Language refers to a person's ability to communicate and find words. And executive function refers to higher cognitive abilities such as planning and making decisions. And our research also found that stroke has the greatest impact in processing speed and executive function, while its memory is least affected. And so this might be one of the defining characteristic of vascular dementia. We looked at cognitive decline over the period where the person has not had a stroke yet, and we found that all the vascular risk factors were significantly associated with faster decline. So these risk factors include diabetes, hypertension, high cholesterol, cerebral vascular disease, and smoking. And so, for example, if someone had diabetes, their cognitive decline was faster than those who did not have diabetes. This is telling us that these risk factors may be exerting their greatest impact before a stroke rather than after a stroke. These risk factors, we already know that they are linked to stroke. So if we try to prevent a stroke, and we know how to do that by, say, following a healthy diet, exercising regularly, not smoking and drinking less, then we reduce our risk of stroke and potentially reduce that subsequent stroke-related cognitive decline and dementia.
The focus in the past in stroke has been on physical deficits from stroke. The importance of recognizing the cognitive cost of stroke is increasingly becoming apparent from these investigations. And I'd like to say two things. One is that you can reduce the impact of a stroke on cognition, firstly by intervening at the time of stroke to salvage the brain. And we know that early intervention in stroke is becoming increasingly available around the country and is the right way to approach a stroke. A stroke should be considered an emergency and dealt with just as you deal with a heart emergency. You should deal with stroke as a brain emergency and come to the hospital immediately, because some intervention, especially using thrombolysis, can salvage the brain, protect the brain. We do not have good drugs currently available to actually help brain recovery immediately after a stroke, or preserving the brain immediately after stroke, but that is an area for development in the future, definitely. Researchers are looking at that very actively. But of course, we need to recognize the patients who've had a stroke who also have cognitive deficits, because cognitive rehabilitation should be combined with physical rehabilitation. And this is something that is currently neglected. And then, of course, we need to look at their long-term risk of cognitive decline after a stroke, because these people, individuals with stroke, are at greater risk of cognitive decline than the general population. So we need to address their risk factors for future decline as well. Not only do you want to prevent another stroke from happening, but you also want to see, even if a stroke doesn't happen, that we have reduced the risk for decline. And we know that also happens even if another stroke doesn't happen. So those are the two messages we want to convey out there, and that consider cognition as a major adverse outcome sometimes, or often in fact, in many patients with stroke, and we can do something about it.